2, 1. We are live, ma'am. Please start.
Namaskar and good evening, everyone. I welcome you all for today's webinar on advances in breast and GI oncology. And with immense pleasure, I would like to invite the program convener, Dr. Satish Sethi, who is Senior Consultant Medical Oncologist at HCG Cancer Center, Bangalore, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Yeah, good evening, everyone. We know that a lot of conferences like virtual and even physical the meetings are happening. And today this meeting is there like to say the what are the updates is there in the GA on the ASCO GA cancer. That is like we have some important studies from the liver cancer and GA cancer and also like in the colorectal cancer. And like they're going to present the important abstract and also followed by that is what is the newer molecule also has come in our immuno-oncology practice in our day-to-day. They're helping us to manage many more patients on rather than conventional treatment, adding up our the treatment of our patient with chemotherapy and along with immunotherapy. We have eminent speakers are there in our list and in the panel, and I like to go ahead this program very successfully, and we can have an interactive discussion. Will be helpful for learning from new data also and experience from each the speaker. I'll request Dr. Amina. She is a fellow in medical oncology from HCG Bangalore. She like to present on the keynote 937 study, the phase 3 data on the adjuvant immunotherapy in hepatocellular carcinoma after the ablation, local resection or the ablation curative therapy. Over to Dr. Amina. Dr. Amina is sharing slides, or are you sharing?
So I'll be sharing the slides, sir.
Yeah.
Shall I stop sharing then, ma'am?
Okay. Otherwise, you can go ahead. I'll just read. Yeah.
Not an issue, ma'am.
Put to the PowerPoint mode, actually, presentation mode.
Anjali, make it full screen. Yeah.
Yeah, Dr. Amina, you can start.
Yeah. Good evening, everyone. I'm Dr. Amina. Thank you, Satish sir, and the entire team for actually letting me speak here. I will be presenting a phase 3 keynote 937 study. It is a multicentric study which is done by Stephen Lamchan et al. It is about adjuvant pembrolizumab given in hepatocellular carcinoma patients who have achieved complete radiological response after surgical resection or local ablation. Yeah, next slide. Next slide, yeah. Treatment guidelines recommend surgical resection and local ablation as potentially curative treatment strategies for patients with newly diagnosed hepatocellular carcinoma. 5-year survival rates ranges from around 60% to 80% for surgical resection and 40 to 70% for local ablation. However, the tumor recurrence is frequent and there remains an unmet need for standard of care adjuvant therapy to prevent disease recurrence and improve the overall survival. This phase 3 randomized double-blind keynote 937 study evaluates the efficacy and safety of pembrolizumab versus placebo as an adjuvant therapy in patients with HCC after surgical resection or local ablation with curative intent. So we present the results of the third interim analysis and final analysis of recurrence-free survival in the study. Next. Coming to the study design, the key eligibility criteria of being age more than 18 years, a confirmed case of HCC with who has achieved complete radiological response after surgical resection or local ablation, and performance status being 0 to 1, and child PUX levels class A The totally of 959 patients were randomized into 1:1 ratio into two arms. First arm being pembrolizumab given 200 mg IV every 3 weekly for 1 year versus placebo given IV 3 weekly for 1 year. Patients were treated until disease recurrence, unacceptable toxicity, and intercurrent illness or withdrawal. And primary endpoints being recurrence-free survival by BICR or by pathology, overall survival, and the secondary endpoints being disease distant metastasis-free survival by BICR or by pathology. Next slide, please. Treatment disposition, totally 959 patients were randomly assigned into pembrolizumab group versus pembrolizumab arm versus placebo arm, and total of 471 patients were treated with pembrolizumab. 282 patients completed treatment and 189 patients discontinued, mostly due to recurrence or relapse or adverse events. In the placebo group, around 482 patients were treated and 337 patients completed treatment, while 145 patients discontinued treatment due to relapse or recurrence or adverse events. A median follow-up of at interim analysis 3 was around 50.7 months. Next slide, please. The baseline characteristics of the patients being an average of median age being around 62 to 63 years, and viral etiology around 60% patients had hepatitis B virus positive in the pembrolizumab arm versus placebo arm, 59 patients, and alpha fetoprotein at initial diagnosis was less than 200 nanogram per ml in around 77 patients in both the arms. And prior ablation being around 80, patients received around 87 patients did not receive any prior ablation, whereas around 88% received prior local therapy, that is resection is in both the arms. And around 83% patients were BCLC stage A, and around 57% patients had microvascular invasion in almost both the arms. Next slide. And coming to the results, which were plotted in Kaplan-Meier curve in the form of Kaplan-Meier curve, shows recurrence-free survival of median recurrence-free survival in the pembrolizumab arm was 46.7%, and versus placebo it was 45.5%. We can see the curves; they don't. I mean, they have overlapping curves in both the arms. So the recurrence-free survival at 24 months was around 63% in the pembrolizumab arm versus 61% in the placebo arm. Whereas when you see at 48 months, it's 50% for both the arms. Next slide. Yeah, and here the recurrence-free survival in the key subgroups are also seen, which is plotted by in the forest plot. And here also, if we have seen, we can see that it is not statistically significant. Next slide. In coming to the overall survival, which is seen at 24 months as 90% in the pembrolizumab arm and 94% in the placebo arm. And coming at 48 months, it is around 79% in the pembrolizumab arm versus 81% in the placebo arm. Next slide, please. Coming to the distant metastasis-free survival, it is at 24 months, it is around 82% similar in the placebo arm and the pembrolizumab arm, whereas at 48 months or so, it is a similar percent, around 71% to 70% in the placebo pembrolizumab versus placebo arm. Next. Coming to the adverse events in all treated patients, most of the adverse events were treatment related. That can be seen around 60% in the pembrolizumab arm and around 35% in the placebo arm. The adverse events were majorly pruritus, which was seen in the more in the pembrolizumab arm, and rash, hypothyroidism, increased ALT and AST, diarrhea, and hyperthyroidism being the major treatment-related side effects. Next slide, please. Coming to the immune-mediated adverse events, which are mostly seen in the pembrolizumab arm, around 26%, whereas 7% in the placebo arm. And most of the side effects are hypothyroidism, hyperthyroidism, hepatitis, and pneumonitis, which is mainly seen. Next slide, please. Coming to the conclusion, adjuvant pembrolizumab did not demonstrate improvement in the recurrence-free survival versus placebo in patients with HCC after surgical resection or local ablation. Recurrence-free survival hazard ratio being 1.06 and p-value is 0.7, which is not statistically significant. The study did not proceed to final analysis as the RFS hypothesis was not met. And per multiplicity, overall survival was not tested statistically. Overall survival hazard ratio is 1.08, and no new safety signals were identified for pembrolizumab monotherapy. Next slide. So the key takeaway points now was that recurrence-free survival did not meet criteria for statistical significance at interim analysis 3, RFS hazard ratio being 1.06, and overall survival was not tested for significance at interim analysis 3 or at final analysis, as the RFS endpoint was not statistically significant. Overall survival hazard ratio was 1.08. So this is not statistically significant. Hence, there still remains the unmet need for adjuvant therapy in patients with HCC after surgical resection or local ablation. Thank you.
Thank you, Dr. Amina. It is a negative study because we have a data coming about the adjuvant atezolizumab and newer data with the Emerald 2 study, durvalumab with bevacizumab. They are coming in a positive way, but this is a negative study because we know that many cases this adjuvant pembrolizumab has made a impact of improvement in the survival. Is a negative study. I think we have to wait for this is the anyway the role is clear. Actually, no adjuvant benefit with this drug, and we have to wait for other drug. And I request Dr. Spurti to present our presentation.
Yes, sir. Hi.
Dr. Spurti, I request Dr. Spurti. She's a consultant medical oncologist working in Apollo Hospital. I request Spurti to present your case.
Yes, sir.
Present your data. Yeah, thank you. Over to you, Spurti.
Yeah, am I audible?
Right?
Yes,
Or
you are
shall we-
audible. Yeah, yeah.
I'll share my slide.
Done,
Yeah.
done.
I'm not able to share my slides because of some privacy issue on my laptop. Hello.
Our behalf.
Yeah.
Anjali, can you share the
Yes,
presentation?
yes,
Dr.
sir.
Spurti, yeah.
Yeah.
Please put in a PowerPoint mode.
Yeah. So today I'll be presenting on the breakwater study. So can you go to the next slide? So as we all know, BRAF V600E mutation is seen in around 8 to 10% of metastatic colorectal cancers. It is usually associated with very poor prognosis, and as a result, we need a strong therapy upfront. So with that in mind, this study was designed. So can you move to the next slide?
Just a second, ma'am. Doing it again.
Yeah, you can go to the next slide.
Just a second, sir.
Yeah.
Can you go to the back? Next slide. So we know that we see BRAF V600E mutations in around 8 to 10% of metastatic cancers. So here we have two targeted drugs in this study. One is the encorafenib, which is a highly selective ATP competitive BRAF inhibitor, and also we have one more drug which is cetuximab. So in the study, we combine encorafenib with cetuximab along with folfiri. Whereas in the earlier studies, we have seen that encorafenib and cetuximab has done very well in later line settings, but not in the first line setting. And also in the breakwater cohort, earlier cohorts, we've seen that it has done very well with modified FOLFOX6. So here we are seeing the cohort 3, that is encorafenib with cetuximab with folfiri. Can you move to the next slide? Yeah, so this is the background of this study. Next slide, please. Yeah, so this is a study in metastatic colorectal cancer in patients with BRAF V600E mutation. They've not taken any other BRAF mutations. And also in adult patients with first line therapy. That is, patient has not received any prior therapy. So we have a total of 147 patients randomized into 2 arms. One arm with EC plus folfiri compared to the standard chemotherapy arm, that is folfiri, with or without bevacizumab. So the endpoints being primary endpoint was overall response rate. The other endpoints being PFS, OS, duration of response, and safety. Next slide, please. Next slide. So comparing the baseline characteristics of patients in both the arms, they are very similar and comparable across both the arms, coming to the ECOG performance status, site of tumor, number of organs involved, and liver metastasis. Next slide, please. So coming to the overall response rate, we see that the EC plus folfiri arm has a 65% response rate compared to 40% response rate in the control arm, which means it is doing very good compared to the standard chemotherapy arm. Next slide, please. The response has been maintained across all the subgroups, irrespective of age, sex, ECOG status, number of metastatic organs, or the site of tumor. Next slide, please. Coming to the overall response, even we can see that even the OS is better in the EC arm compared EC plus folfiri arm compared to the control arm. The duration of response has not reached yet, which means that patients who are responding are actually responding durably. Next slide, please. So coming to safety, there are no new safety concerns seen in the EC and full-free arm compared to the control arm. Whatever the adverse events are seen are those that of the study drugs, which we usually see. Next slide, please. So the most common side effects were nausea, diarrhea, vomiting, and alopecia, which were comparable across both the arms. Next slide, please. There were no unexpected safety cautions that were raised during the study. Next slide, please. There was modifications also were not many. It was comparable across both the arms. So to conclude, we can see that irrespective of the backbone, whether be it full-free or full-fox, EC has done better when it comes to overall response rate and OS. Next slide, please. Yeah. So this tells us that since BRAF V600E is the primary mechanism driving the cancer in this metastatic colon cancer, we need to target that. We can add a full fox backbone or a full free backbone. So both have shown good responses. Thank you.
Yeah, and thank you, Dr. Spurti, to taking about the journey of BRAF, how to treat the BRAF mutation in colorectal cancer through the breakwater study. See, like the problem is about challenge of the availability of the drug, about the encorphenim. Cetuximab and other drugs are available, but most of the time we need to treat with the bevacizumab only. Like yeah, even though have that duration of control is to be maybe short-term benefit, but we are learning actually to with this treat with the new drug. Very interesting. Okay. I'll request. Yeah, thank you, Dr. Spurti. I request Dr. Aditya. He's a consultant medical oncologist at HCG Bangalore. I request Dr. Aditya to present on his presentation on GE cancer. Over to Dr. Aditya. Aditya, are you sharing or like the organizer has to share your presentation? Aditya?
Sir, can you hear, sir?
Yeah, yes, we can hear Aditya. You can put in a presentation mode.
Okay, sir. Sir.
Yeah, we can hear you. Yeah.
Sir, slides are visible, sir?
Yes, slides are visible. You have to put in a presentation mode, Aditya.
Sir, I've put in presentation mode.
No, it is coming. Just see that.
Okay, sir. I've put, sir, in presentation actually.
It is there like presentation mode that you have to. Like,
yes, sir. I'm pressing present. It is coming the enter screen. It is showing for me.
Maybe it's delay is there, I think.
Is this okay, sir?
That's okay. Like you can start, but it's not coming like full presentation mode. Okay, you can start, Aditya. Okay.
Yes. So good evening, everyone. I'm going to present phase 2 Illustro trial, which is phase 2 update from ASCO GI 2026, where first line a subset of zolbetuximab with Folfox along with nivolumab was given in patients with HER2 negative and Claudin 18.2 positive gastric and GE junction adenocarcinoma. So agenda background. Claudin 18, so these are the main headings which I'll be discussing: background and unmet need, the Claudin 18.2 biology and rationale, Illustro trial design, efficacy and safety results, and conclusions. So gastric and GE junction adenocarcinoma remains a major global concern, cancer burden, and with poor prognosis in advanced and metastatic settings. There is a need for further biomarker-driven first-line therapies apart from immunotherapy and anti-HER2 therapies. So current first-line landscape, the treatment is platinum with fluoropyrimidine chemotherapy backbone and addition of immunotherapy in patients with PD-L1 positive patients. So there is a need for additional targeted strategies. So Claudin 18.2 is nothing but it is a transmembrane tight junction protein it is expressed only in gastric mucosa and in normal gastric mucosa rather than in normal tissues, and it is often retained in gastric cancer, and it is ectopically expressed in metastatic lesions, and also in other cancer types. So this tight junction protein can form as a novel target for patients with gastric as well as GE junction adenocarcinomas. Um, so this is the basis for the targeting Claudin 18.2. So it is mechanism of action. It is monoclonal antibody targeting Claudin 18.2, and it reduces antibody-dependent cellular toxicity and direct tumor cell killing. So based on this one, in this trial, we are combining chemotherapy along with zolbetuximab and nivolumab. So the rationale for combination therapy is chemotherapy enhances antigen release because of tumor cell killing, and zolbetuximab targets Claudin 18.2 positive cells, and nivolumab enhances immune response after antigen release. So Illustrator trial is a phase 2 multi-cohort study. It evaluates zolbetuximab-based combinations and multiple lines of, and in this multiple lines of therapy are exposed. Means in this trial, different cohorts are there: cohort 1, cohort 2, cohort 3, and cohort 4. Each has a different has different regimens, and usually I'll next show the study design. In this phase 2 study, cohort 1 patients received zolbetuximab as monotherapy, whereas cohort 2 patients received zolbetuximab along with FOLFOX, and cohort 3 patients received zolbetuximab with pembrolizumab. So in up till cohort 3, pembrolizumab was the immunotherapy, whereas in cohort 4, zolbetuximab along with nivolumab was used. In cohort 1, 2, and 3 did not show any response. The overall response rate was very less. It was less than 5%. So the cohorts were discontinued. Whereas cohort 4 study design showed good treatment response in terms of overall response rate as well as PFS. So cohort 4 was continued in this phase 2 study. So the key eligibility criteria were previously untreated, locally advanced, unresectable, or metastatic gastric or GE junction adenocarcinomas, which were Claudin 18.2 positive, moderate to strong Claudin 18 staining in more than 50% of the tumor cells. So if it was more than high, it was further divided into intermediate expression and high expression. Intermediate expression was there in those with between 50 to 75% of the cells were expressing Claudin 18, whereas high was in those patients where more than 75% of the cells were expressing Claudin 18, and the patients had to be HER2 negative with ECOG performance status of 0 to 1. So it was further divided into cohort 4A and 4B to decide on the dose of the zolbetuximab. Both the cohorts were almost similar except for the difference in the dose of the zolbetuximab. Whereas nivolumab was 240 mg and modified 446 regimen was used. So in cycles 1 to 4, zolbetuximab was used along with nivolumab and FOLFOX, and cohort 4B also similar regimen was used, but the dose of zolbetuximab was 800 mg instead of 600 mg and per meter squared. And further, cycle 5 were similar in both the cohorts. The endpoints and analysis were PFS, overall response rate, and duration of response, OS, and safety and tolerability. Right now, till 2026, PFS data has been published, whereas further OS data and safety profile has been published. Whether further OS data is still under study. So in this study, the demographics, median age was around 61 years, and it was majority were male compared to female, and most were Asian in Asian race, belong to the Asian race. And previous treatment allowed by surgery alone, followed by surgery, followed by chemotherapy, and chemotherapy followed by surgery. This was in cohort 1, 2, and 3, whereas in cohort 4, the eligibility criteria was patients who had to be previously not treated, locally advanced or metastatic. So, and Claudin 18 expression, it was high was seen in 65% of the patients, whereas intermediate was seen in less 11 of the patients out of 77. PDL1 status, CPS was more than 1 in 49 patients of the 77 patients, and CPS less than 1 was seen in 26 number of patients. So more than PDL1 positive who had Claudin 18 expression, they also had PDL1 positive. So here, based on the results, the PFS stratified by Claudin 18 expression, it was divided into high and intermediate. Among the patients who had high expression of claudin 18, there are 23 events, that is 39% compared to compared to 63.6 in intermediate. So patients who had high claudin 18.2 and who were treated with zolbetuximab had lesser events compared to those with intermediate expression, and median PFS was also high in cohort B, 4B patients, that is those who were treated with higher dose of zolbetuximab compared to lower dose of zolbetuximab, and PFS was 18 months compared to 6.7 months, depending on the expression. And in PFS in cohort B, median PFS was 14.8 months when patients were treated with zolbetuximab along with modified FOLFOX as well as with nivolumab. And the number of events has been mentioned, that is only 43% had any progression, and median PFS was 14.8 months, which was higher in cohort 4B, that is with higher dose of zolbetuximab compared with lower dose of zolbetuximab. So coming to the safety profile, in cohort 1, 2, and 3, these were discontinued because the response rates were very less, whereas 4A and 4B were continued. And patient also had most of the side effects were GI side effects like nausea, abdominal pain, vomiting, and constipation. And grade 3 also were more in the GI side effects were seen, which were grade 3 compared to hematological side effects. So the conclusion in this study is the triplet therapy with zolbetuximab with modified FOLFOX and nivolumab led to encouraging PFS in cohort 4B of Illustrator trial. Median PFS was 14.8 months, and the response seen with zolbetuximab when combined with chemotherapy and nivolumab showed a better response if the claudin expression was high compared to intermediate, and those who had high expression of claudin 18 and who had PDL1 positive status had even higher median PFS of 23 months compared to 12 months who were claudin 18 intermediate claudin 18 and PDL1 negative. So the best subset was those who expressed claudin 18.2 as well as who had PDL1 CPS more than 1. So this triplet therapy was beneficial for this subset, was very beneficial for this subset, and overall response rate was 62.1% with measurable in patients with measurable disease, and 68% in patients with high claudin 18.2. So based on this study, the triplet therapy approach presents as a promising strategy for patients with claudin 18.2, HER2 negative, locally advanced unresectable gastric or GE junction adenocarcinoma. So the results of this study have formed the design for the phase 3 Lucerna trial, which further is a phase 3 double-blind randomized controlled trial for patients expressing claudin 18 and who are PD-L1 positive and HER2 negative. So based on this trial, key takeaway points were this trial led to encouraging PFS in cohort 4B, that is high dose zolbetuximab with modified FOLFOX 6 regimen with nivolumab across patient and biomarker subgroups. The effect was more in patients with claudin 18.2 high expression and PDL1 positive patients, and this also showed an acceptable safety and tolerability profile. Most of the side effects were GI side effects, and they were acceptable. Mostly were nausea, vomiting, and constipation. And this trial it paved the design for Lucerna trial, which is a phase 3 randomized control trial. And this trial also showed a promising treatment strategy for HER2 negative, locally advanced gastric or GE junction adenocarcinomas with high expression of claudin 18 and PDL1 positive patients. Thank you.
Thank you, Aditya. It is excellent presentation. Like it's a very important. Like Claudin 18.2 is one of the things that we started doing. Is adding up the therapy that I think like immunotherapy doesn't work where the target is positive. there are two things actually. HER2 positive, where with the expression of PD-L1 is there, there is anti-HER2 therapy when PD-L1 will work, and PARP inhibitor with the immunotherapy that works synergistically. And this is one of the other thing, target therapy, it may work synergistically with immunotherapy, immune checkpoint inhibitor. I think most of the other target therapy doesn't work. Is definitely we should explore the options actually that many times we may not find like we try to work up actually we don't do the testing actually cladding like we try to do in the third line, fourth line, and I think that you should explore these options. Very, very impressive data. Thank you, Dr. Aditya. I request Dr. Ravi. Yeah, thank you. And I request Dr. Ravi Tippesamy. He's a senior medical oncologist at HG Bangalore and the Sparsh Hospital. He's going to deliver the talk on the immunotherapy in stomach cancer. Over to Dr. Ravi.
Yeah. Thank you, Satish sir, for giving this opportunity. I thank Glenmark. So, as we all know, I think GI malignancies is one of the common malignancies what we see in our day-to-day practice, and we will see how the tislelizumab has changed the way we practice in esophageal squamous and gastric cancer. Next slide. So, as we know, now there are a lot of drugs, immunotherapy drugs, which are available. We have got Pembro, Nivo, we have got Tisley, Serplulimab, Atoripilimab, and we have got Nivo generics. But each has got their own potential. If we see tislelizumab, though it is a PD-1 inhibitor, there are a lot of differences and advantages of Tisley over other molecules. So we will discuss how Tisley scores over other molecules. Next slide. So these are the current approved PD-1, PD-L1 inhibitors. Nivolumab was the first PD-1 inhibitor in 2014. And then a lot of molecules have been approved in almost majority of the solid tumor malignancies and also in some hematolymphoid. If we see tislelizumab, it has got various approvals in solid tumors and also in Hodgkin lymphoma. So it is a very promising molecule, and we will see the evidence how we can incorporate Tisle in our day-to-day practice. Next slide. Next slide. So as I said, though they are all common PD-1 inhibitors, Tisli is slightly different. It is an humanized IgG4 monoclonal antibody with a very high affinity and binding specificity for PD-1. It is the binding, it differentiates by its unique epitope and also different pharmacokinetics. The standard dose recommended is 200 milligrams, similar to Pembro. Next slide. So if we see the approval, it has got almost all the approvals of Pembro or Nivo. If we take nasopharyngeal, GI malignancies, lung, urinary bladder, Hodgkin lymphoma, or any blank approvals like MSI or DMMR tumors, Tisley has got very good data. And we are using in our day-to-day practice also. Next slide. So it has got a distinctive binding orientation, so the receptor affinity is very high, and the blockade is complete compared to the other molecules. If we see Pembro and Nivo, the PDL1 blockade is only about 80%, but if we see Tisli, it is more than 99%. That's why I told it's a different molecule, and even in our own practice, we have seen the difference in terms of responses and longevity. Next slide. Next slide. Next slide. So this is a unique pharmacodynamic advantage of Tisli since it has got a good binding to the receptor. So the blockade is almost 100%, and that's why the efficacy of molecule is better as compared to the other PD-1 inhibitors. If we see the indication, as I told, it has got very broad indications in majority of the solid tumors, especially nasopharynx, lung, GI malignancies, and also in Hodgkin's and blanket approvals for DMMR or MSI high tumors. Next slide. Next slide. Next slide, please. Yeah. And there are various ongoing trials also, which I think in due time will get, say, the data will be matured. Coming to the topic of interest today, the GI malignancies, we'll discuss how Tisli has improved the survival in esophageal cancer and gastric cancer. If you see the burden, as a medical oncologist, we see GI malignancies is almost 50% of our practice. And in GI malignancies, esophagus and stomach comprises a significant burden. Next slide. So if we see the epidemiology, generally we see at older age, males are affected more as compared to the females. And majority in the upper esophagus, it is squamous, and it is a GE junction, it is adeno. Next slide. And the 5-year survival is very dismal if we don't give immunotherapy. So as I discussed, in upper third, it is squamous, and in the GE junction, it is adenocarcinoma. Next slide. Next slide. So the rational 306 is very important. In the first leg esophageal squamous, study. Next slide. If we see the rational 306 study, it is a multi-center global study where almost around 649 patients were enrolled. Next slide. So for the inclusion criteria, they were all unresectable, locally advanced or metastatic esophageal carcinoma. It is in the first line setting, where one arm received the standard of choice chemotherapy with Tisli, and other are only chemotherapy. So they were substratified based on the PDL1 status, and the primary endpoint of the study was OS, overall survival, which is a robust endpoint. Next slide. So coming to the results, if we see, is a positive study. It meets primary endpoint. There was 34% reduction in the risk of death and additional overall survival of 6.6 months. So which is highly significant. Next slide. Coming to the secondary endpoints of PFS, objective response rate, and a depth of response. Again, this was a positive study in all the subgroup analysis and secondary endpoints, which gives us confidence that adding Tisley to the chemotherapy backbone improves the survival. Next slide. Coming to safety and tolerability, there were no additional, say, concerns with Tisley. The standard immune side effects like hypothyroid and skin toxicities were commonly seen. But if you see the grade 3 4 toxicities were all very minimal as compared to other IO data. So there were no new additional safety signals. Next slide. Coming to the next setting, which is in the second line setting, 02, where Tisley was compared with the chemotherapy in the second line setting of esophageal cancers. Next slide. So if we see the study design, again, it's in the second line setting here as compared to the previous, which was in the first line. Advanced metastatic esophageal cancers were involved, and one arm received Tisley alone, and the other arm received the investigator of choice chemotherapy. Again, the stratification based on the PD-L1 status, and primary endpoint again here is a overall survival, which is a robust primary endpoint. Next slide. So if we see the overall survival, it is a positive study. The primary endpoint was met. There was 30% reduction in the risk of death. Next slide. And if we see the secondary endpoints of PFS, objective response rate, and duration of response, again, it's a positive study which met its secondary endpoint. Next slide. Next slide. Yeah. Again, the safety and tolerability, there was no new safety concerns. The display as compared to other IO, it was a side effect profile which we saw, and they're all easily manageable. If we see the of Tisley with other drugs, Tisley scores better because, as I discussed, the binding of Tisley is different as compared to other IO drugs, and that's why even with the indirect comparison as compared to other IO drugs in the similar setting, the responses what we get Tisley is much superior as compared to other IO drugs. Again, some technical glitch. So next, one more last trial is there in my presentation, that is Tisley in lung cancers. Sorry, Tisley in GI malignancies. Next slide, please. So coming to the gastric cancer, next slide. If you see again, the incidence is very high, especially in the southern part of India where we practice. Next slide. Next slide. Next slide. We'll directly go to the trial. So this is the Rational 305 study where Tisley when combined with chemotherapy has shown superiority as compared to chemo alone. If we see the inclusion criteria, it is a typical inclusion criteria what we see. Gastric cancer or GE junction, HER2 negative. It is in the first line setting. One arm received Tisley and chemotherapy, and the placebo arm received only chemotherapy. The primary endpoint again here is robust overall survival. Next slide. So if we see the results, all the subgroups are well matched, and even the PDL1 score was well matched in both the arms. Next slide. Coming to the results, the primary endpoint of overall survival, it is a positive study which suggests that adding Tisley to chemotherapy will significantly improve OS at the landmark analysis of 1 year, 2 year, and 3 year. And if you see any difference between, say, the TAP score or PDL1 percentage, it is negative. All the subgroups did not benefit. Those who are PDL1 positive, the magnitude of benefit is much higher. Next slide. If we see the secondary endpoints, the PFS, objective response rates, again, it's a positive study which suggests that adding Tisley to the chemotherapy backbone will give a significant benefit, not only in the overall survival, but also at other endpoints like PFS, objective response rates. Why these PFS objective response rates are important? Because patients will get symptomatic benefit very early. Next slide. So safety concerns, again, there were no new safety concerns. They're all the standard IO safety concerns, and the majority are grade 1 and 2, which are easily manageable. If you see the grade 3 and 4, the percentage is very minimal. Next slide. So again, if we see the available data and cross comparison, when we compare Tisley with the Pembro and Nivo, the magnitude of benefit, PFS, OS is significantly higher in Tisley as compared to Pembro and Nivo. Again, because of the differentiator here is the mechanism of action PK/PD of Tisley is different as compared to Pembro and Nivo. Next slide. Next slide. So if we see the guideline recommendation, because of this robust data of the rational study, the Tisley with chemo is recommended in the first line and second line setting in the esophageal cancers. And in gastric cancer, it is recommended in the first line along with the chemotherapy. We have got our own experience also of using Tisley in the above indication. And definitely what we have seen is it's a very safe molecule. The side effect profile is very minimal. And the responses what we get is very durable. So we have used in many patients the Tisley in various indication, and as compared to the molecule, initially we were skeptical, but seeing the results now we are very convinced that Tisley with chemotherapy or Tisley alone in esophageal second line, wherever the approval is the standard, it should be the standard of care. Next slide. So with this, I'll conclude. Thank you.
Thank you, Dr. Ravi, for excellent talk on the management of immunotherapy in GE junction esophageal cancer. Any questions here you can ask, or we will move on to the next talk. Anyone wants to ask question in the chat box, you can ask. I request Dr. Vinu Sarthi, who is a consultant medical oncologist working at Baptist Hospital. I request Dr. Vinu to talk on the immunotherapy in breast cancer, triple negative breast cancer. Over to Dr. Vinu.
Good evening, sir. Thank you, Satish, sir. I'll just share my slides screen. Hope my screen is visible, sir. Yes. First of all, thank you to Satish, sir, and thank you to Dr. Reddy's lab for this opportunity. Over the next 10 minutes, I'll just quickly go through Torchlight trial, which shows a very promising new immunotherapy, especially in the difficult space of triple negative metastatic breast cancer. So this is mainly focusing on the Torchlight trial. So coming to a brief background, we know triple negative accounts for almost one-fifth of all the breast cancers, possibly higher in India, and it's a worse prognosis because we have very limited treatment option because of lack of targetable mutations or targetable receptor actionable mutation. It is said to have a tumor mutational burden high of in around 10% of the patients, but however, we don't see a response in most of them, and we see that around 40 to 50% of them show some form of PDL1 expression. So with this theory in mind, there's the rationale that chemo can induce immunogenic cell death and it can work synergistically with checkpoint inhibitors to improve the immune activation. With this background, the early phase 1 toripalimab, a humanized PD-1 antibody, it is unique because it binds to a different loop in the PD-1 receptor compared to nivolumab or pembrolizumab, and it showed a promising anti-tumor activities. So with the phase 1 data, they proceeded to the phase 3 Torchlight trial. So coming to the schema of the trial, they typically took the triple negative metastatic breast cancer with almost 85% of them treatment naive and around 15% of them received some form of taxane therapy, not amenable to surgery. And they randomized them 2:1 toripalimab 240 mg 3 weekly and nab-paclitaxel day 1, day 8, 125 milligram per meter square every 3 weekly versus placebo and nab-paclitaxel. And they were stratified based on PDL1 expression, whether first or second line of therapy and previous taxane exposure. And the primary endpoints were PFS based on a blinded independent review committee based on PDL1 subgroup, and secondary endpoints are OS, 1 year and 2 year OS, PFS, overall response rate, duration of response, and disease control rate. Now, as you can see, the patient demographics, they were pretty well balanced in both the groups. Whether the PD-1 positive subgroup or the final intention to treat analysis, they were all well balanced. The PD-1 status, if you see, around 37% of them were PD-1 negative patients and almost 63% of them were PD-1 positive, in which CPS 1 to 10 comprised around one third and CPS more than 10 around 25 to 26%. And around 18 to 20% had previous paclitaxel therapy, and around 95% of them are first line and only 5% of them the second line therapy. So if you see the Torchlight results, primary PFS based on PDL1 subgroup, positive subgroup. So in PDL1 positive subgroup, you see that the graph is early, there is an early divergence of the graph at around 4 to 5 months. And as we typically see with the immunotherapy response, there is the plateauing of the curve where we see some exceptional responders who may continue to respond for a long time. It showed a good 8.4 versus 5.6 months benefit and 2-year PFS rate of almost 10% extra gain in the toripalimab arm. This translated to a 35% reduction in risk of death. If you see the forest plot, if you see almost whether any subgroup, age, ECOG performance, PDL1 expression, whether it is 1 to 10 or more than 10, all were leaning towards the toripalimab arm. And only age greater than 65, but this was a small subgroup, and possibly because the older age group and small subgroup, it cannot be commented on, which was leaning towards the placebo arm. So subgroup analysis of the PDL1 positive subgroup. In the PDL1 positive subgroup, whether the site of mets was lung, bone, or brain, whether previous neoadjuvant therapy was given, previous surgery, previous radiation, all showed that toripalimab was a better arm compared to placebo. And when there was the intention to treat population, and they also included the PDL1 negative population, even this population, it showed that the PDL1, rather PDL1 blockage with toripalimab showed a superior response with a 23% reduction in risk of progression of death, 8.4 versus 6.9 months. And again, if you see the forest plot, it is almost the same. Almost most of it, 90% is favoring the toripalimab arm. The few things which is favoring the placebo arm, whether previous paclitaxel or the age more than 65, they're a very small subgroup, so it would be incorrect to just comment on them as they were a very small representative population. Coming to OS, in the subgroup analysis of OS, this also trended towards a much better OS benefit with toripalimab, be it the site of metastasis, previous therapies, previous surgery, or previous radiotherapy. So OS based on the blinded independent committee review in the PDL1 subgroup population. So even in PDL1 CPS less than 1, toripalimab trended towards a better OS benefit, 33 versus 27.9 months. In PDL1 1 to 10, we see that there is a clear separation of curves around 1 year and it continues. So you have a group of people who do extremely well. Initially, the curve you see the non-responders and they're converging, but then you have this group who respond and continue to respond for quite a long time. And of course, in the PDL1 more than 10 CPS group, you see an even more robust response and a sustained response. Uh, the response rate, if you see, is of course overall response rates in the PD1 subgroup 66 to 68%. But what you see is the complete response and partial responses are slightly more higher, the toripalimab group, and the duration of response, the ones who respond, they continue to respond a lot better on the toripalimab group. And this is similarly mirrored even on the intention to treat analysis. Safety profile, as you see, there was the grade 3-4 serious adverse events were not much higher with the toripalimab compared to the chemotherapy. What they traditionally saw were the expected side effects with immunotherapy, be it the rash, hypothyroidism, some transaminitis. Very rare, hardly 2 or 3 patients required a serious required discontinuation due to a serious AE adverse event due to immunotherapy. So what they concluded was the phase 3 Torchlight trial, addition of toripalimab to nab-paclitaxel provided significant improvement in PFS and reduced the risk of disease progression or death by 35%. The OS also showed a trend towards improved OS in both intention to treat and PDL1 population. So this was an interim analysis and it met its primary endpoint. It was manageable safety profile and the final analysis of PFS and the final analysis will be statistically tested in the future. So what was interesting was till now we had only pembrolizumab approved, especially for the CPS more than 10. So we didn't have any molecule for the 1 to 10 subgroup, and possibly toripalimab fits in very well to this population where many patients may have missed immunotherapy, and we could safely or very effectively use toripalimab within the even all PDL1 1 to 10 population. Thank you.
Thank you, Vinu, for excellent talk on the role of immunotherapy, toripmap in triple negative breast cancer. Yeah, yeah. If you go for that PDLN score less than 10% is like we'll tell like is a 1 to 10%. The DAC out test will say that is a negative, but the pembrolizumab approval is a more than 10% only. It's a positive. We say that 1 to 10% may be low positive other thing, but the data is not very impressive. That definitely this immunotherapy has made a good the impact here. This is one of the unmet need in the treatment of triple negative breast cancer. We don't have that because all the cases are not a BRCA positive. We have that only the chemotherapy is one of the backbone of our treatment of triple negative. Yeah, immunotherapy definitely adds on the disease control. It's a good thing. This molecule is adding up the disease control. Thank you, Dr. Vinu.
Thank you,
I
sir.
request. Thank you. I request our next speaker, Dr. Mansi. She's a senior medical oncologist working at Sparsh Hospital. She is going to talk on that role of immunotherapy in nasopharyngeal cancer. I request Dr. Mansi to start your session. Over to Dr. Mansi. Dr. Mansi, are there?
Hello, sir. Maybe ma'am. Yes, sir. Ma'am is here.
Okay. Anjali, can you share the slide? Or Dr. Mansi is going to share a slide.
Sorry, there was some technical glitch.
We are sharing, ma'am.
Sure. Right. So, thank you, Satish sir and Dr. Reddy's for this opportunity. So I'll be talking about how we have found a practice-changing molecule in nasopharyngeal cancers in the recurrent and metastatic setting. Next slide, please. Right. So we know that NPC does not behave like the usual keratinizing squamous cell head and neck cancers that we see in our country, which are more tobacco related. It is very, very distinct. It is characterized by a different geographical distribution and is prevalent in East and Southeast Asia. Though India is amongst the top 5 countries which has this cancer, but we still have a very low incidence, less than 1 in 1 lakh, whereas China has the maximum number of patients with this disease. Next slide, please. So in India, as I said earlier, nasopharynx is quite a rare cancer. We have many other cancers which are more commoner than this, and we may see majority of the cases from Northeast. Next slide, please. So even though head and neck is the leading form of cancer, NPC is less than 1 in 1 lakh, and the highest adjusted rates were found in Northeast states, with Kohima in Nagaland being the highest, 19.4 in 1 lakh population. Apart from NPCs, we have also seen our southern states, Andhra Pradesh, Karnataka, and Tamil Nadu having some cancers, but I'm sure a lot of us see this cancer more from our international patients than our national patients, unless they are from northeast part of India. Next slide, please. So the current treatment options for recurrent metastatic or metastatic first-line NPC, we'll be talking about that. So till 2023, if we had a locally advanced case, we would usually give neoadjuvant chemotherapy followed by CTRT. We would usually use GemCis and in some patients TPF, though we had data that GemCis is better or at least good enough before CTRT. And in recurrent metastatic disease, from a very long time, we've been using GemCis as the preferred choice of chemotherapy drug regimen. Next slide, please. So this was the first study. Keep going. So this was GEM 20110714 study, which was again a China-based study. Most of our trials for NPC do come from China. So this had about 360 patients with 180 patients in each arm. It compared GEM-CIS for 6 cycles versus 5FU and CIS for 6 cycles. And in this study, we saw that the PFS with GemCis was better, significant, statistically significant with P less than 0.001. 7 months in GemCis versus 5.6 months in 5FU and cisplatin. This was the study which only studied the PFS. Next slide, please. That was the primary. One sec. Can you just go back? Right. So the overall survival in this also was there, but it was a secondary endpoint and it was 18.6 months versus 22.1 months. Next slide, please. So far we had about 22 months of OS in this, based on this particular trial. We've had a lot of trials which have given us these immunotherapy related data, but most of these trials, be it Keynote 048 or Checkmate 141, they excluded nasopharyngeal histology. Most of these trials were also in the Western countries and they didn't have that much burden of nasopharyngeal cancer, so they categorically excluded. So we don't have data on these molecules in the first line setting, first line recurrent or metastatic setting. Next slide, please. Keynote 122 was one study in which we did study pembrolizumab in nasopharyngeal carcinoma. It was in the recurrent metastatic EBV positive study, but this was in second line in patients who had prior exposure to platinum. And this was a negative trial. if you see, the response rates were also poor, 21.4% versus 23.3%. Disease control rate was also poor, 50.4 versus 63.8%. So this study did not significantly improve any of the endpoints, be it overall survival, PFS, or ORR versus chemotherapy. So we completely dismissed immunotherapy in the second line setting based on this trial, Keynote 122. Next slide, please. So then came this molecule that I am talking about today, toripalimab. It is a different kind of immunotherapy molecule. It is a humanized IgG4 PD-1 blocking antibody, and theoretically, it is supposed to have a prolonged binding compared to the other antibodies, and it is the first and only category 1 immunotherapy molecule which is approved in recurrent locally advanced or metastatic nasopharyngeal carcinoma, first line treatment. Next slide, please. So I think we've gone through this multiple number of times, but we do have some of the hypotheses which do suggest that this is theoretically a very different molecule. It is independent of glycosylation of the FG loop of PD-1, and it also has higher affinity, binding affinity, irrespective of glycosylation status. It also has a slower dissociation, so it binds faster, binds more, and it dissociates slower, making the receptor availability or binding much longer than the other molecules. It has also shown in some studies that the potency of this molecule to activate CD8 T cells is irrespective of PDL1 expressing APCs or tumor cells. So it also causes more interferon gamma secretion compared to pembrolizumab. But all of this is theoretical. It is all in molecular diagrams and structures, but what really matters is the clinical outcomes, and that was studied in the trial. Next slide, please. So Jupiter 2 was the randomized trial which made this practice changing kind of impact in our practice. Next slide, please. Jupiter 2 was a randomized double-blind multicenter phase 3 trial where primary metastatic nasopharyngeal cancer or recurrent after curative intent therapy patients were included. They were treatment naive for recurrent or metastatic disease, and they were stratified by ECOG status, and just PS0 and 1 were allowed. 289 patients were randomized 1:1 with GEM-CIS 3 weekly up to 6 cycles, followed by placebo as maintenance. This was compared with the arm containing toripalimab, which had 240 mg of tori with GEM-CIS every 3 weekly for 6 cycles, followed by tori maintenance, and this was continued up to progression or up to toxicity. And the primary endpoint was PFS, it was BIRC, so it was blinded. Secondary endpoint was PFS as per the investigators, ORR, duration of response, DCR, OS, PFS, and OS 1 and 2 years. Next slide, please. The patients were very well matched, be it age, gender. Both the arms had recurrent and metastatic patients in equal numbers, and both the arms did have PDL1 status more than 1% or less than 1%. They were quite equally matched. Next slide, please. So as per the first data that was published, this was final PFS primary endpoint as per BIRC. It showed a hazard ratio of it showed, I think, 48% reduction in risk of progression of death, and the median PFS was 21.4 months, which was the OS which we saw in the previous trial, right? So the PFS itself was as much as the OS, and the PFS in the chemo arm was 8.2 months. 1-year PFS rates 59% versus 32. 2-year PFS rates were also quite widely different. So 21.4 months versus 8.2 months of PFS was something which we had not seen. 13.2 months of extended PFS. Next slide, please. The subgroup analysis, it was not well powered, but the benefit was seen across all groups, irrespective of the EBV copy number status, irrespective of the PD-L1 expression and histology subtypes. Some were non-keratinized and some were unclassified. Next slide, please. So the secondary endpoint, which was OS, which we obviously look for much more than PFS, also was very, very strong. So it sustained OS benefit across. In fact, the curves are even separating more widely after 3 years. So median survival follow-up at 36 months showed 37% reduction in the mortality risk. And we also have further long-term data. Can you go to the next slide, please? So in ESMO Asia this December, the long-term OS data was also discussed. Next slide, please. So we have the longest OS data in this study, which updated OS analysis was presented in ESMO Asia. The cutoff was till June 2025, so very, very recently. And we saw a median OS of 64.8 months, which we have never ever seen earlier in this setting. So beyond 5 years, median OS was seen, and 0.62 was the hazard ratio for death, and 38% reduction in the risk of death was seen. So this is unprecedented overall survival benefit, 64.8 months versus 33.7 months, which is very significant. Next slide, please. So coming to response rates, also the response rates were quite good with this combination. The CR rates were nearly 39 patients versus 19. Partial response was almost similar, but complete response, as we know with immunotherapy, there can be far more patients who can actually go in CR if they have that immune recruitment around them. So, and difference in ORR was 11.4%. Median duration of response was almost triple, 6 months versus 18 months as well. Next slide, please. Safety wise, there was no added toxicity. Yes, the kind of toxicity that we see with immunotherapy drugs was seen, but if you see that they did not lead to any extra number of deaths. There was some discontinuation which was seen in the Tori arm, but the number of deaths were not that much, and the number of grade 3 adverse events weren't too much. Of course, IRAEs were only seen in the Tori arm. They were seen in 50 patients, but out of that, only 8 patients had grade 3 toxicity related to immunotherapy. Treatment interruption was almost similar in both the arms. So most of the toxicity that we see is related to GemCis, since this also contained GemCis. But it was only the immune-related adverse events which was slightly more in the Tori arm, and expectedly so. Next slide, please. Right. So as I was saying, grade 3 adverse events were almost the same in both the arms. IRAs were obviously more hypothyroidism, diarrhea, but all of that in grade 3, the only worrisome part was pneumonia, which we do see in a lot of our IO patients, but nothing of that translated into extra number of deaths. Next slide, please. Again, it just emphasizes that though there was some adverse related, immunotherapy related adverse events, but if you see the dark blue ones, they are the only ones which were grade 3 and above. The others were very well manageable, and pneumonia is the only one which was something to be watchful about. Next slide, please. So, based on this Jupiter 2 trial, NCCN made a dramatic shift from what we were practicing earlier to now. In 2026, the category 1 indication is cisplatin gemcitabine plus tori instead of just gem and cis, and it is the only immunotherapy molecule which has category 1 recommendation in NCCN guidelines. Next slide, please. So again, the same thing. Next slide, please. So this is cross-trial comparison, which all of us are not very comfortable with, but we still end up doing it. So this is the longest data that we have for long-term data, median OS of 64.8 months versus 33.7 months. ORR also we can see. So in rational, rational 309, which saw Tisley being studied, if you see the median OS in the comparator arm is almost the same, 31.8 months. However, in the experimental arm, it is quite significantly lower, almost 20 months of difference is there. We'll talk about the other two molecules later because the data is not yet mature. But so far, Tori has the longest overall survival in this setting. Next slide, please. So to conclude, this is definitely practice changing. I don't think there is any doubt in any of our mind that this is something which is not yet OS has not been seen or something. We all agree with this, and I don't say this because it's a Reddy sponsored session, but definitely GemCis plus Tori is the new standard of care for first line treatment of recurrent metastatic NPC. Thank you.
Thank you, Dr. Mansi, for excellent taking the journey of immunotherapy in nasopharyngeal cancer. You extensively spoken about the other immunomolecule, their data. We know that like this because many cancer, Pembro is coming is the winner, and in nivolumab actually this drug is definitely made a change in the manner and the outcome. We have seen that because theoretically and also practically and data definitely is FDA approved. It's not like we are challenging, and even this drug is overcoming that because I personally experienced a lot of the molecule failure to this molecule like previous like nivolumab and pembro also we have tried with this molecule in other cancer also.
Right.
Definitely it is definitely is helping. That is definitely like the what theoretically we say that is stronger binding and also like delayed dissociation, all the things like whatever theoretically we say that even the practical results are there. We have tried to see that, but only thing is number of nasopharyngeal cancer are less, and being involved in the even phase 4 studies also like we are included in that one like we recorded almost 8 cases. Definitely is like we are getting the good results in nasopharyngeal cancer. Any questions from audience? Anything? Like I will go to the next session. Thank you, Dr. Mansi, for excellent. Yeah.
Thank you.
Thank you. Thank you. I request the next speaker, Dr. B.J. Srinivas, a senior medical oncologist at HG Bangalore. He's going to take the journey of the nausea vomiting, how we manage the chemotherapy-induced nausea vomiting, especially when not dealing with the neo drugs ADCs. He's going to talk on that one. I request Srinivas to take start your session. Over to Srinivas.
Yeah, thank you, sir. Shall I share my slides?
You are sharing, Srinivas?
Yeah, I'm sharing myself.
Yeah.
I think it is visible now. My slides are visible.
Yes, Srinivas, it's visible. You can start.
Thanks, thanks, Dr. Satish and Glenmark team to giving this opportunity. So this topic is expanding the horizon of chemotherapy-induced nausea, vomiting, and prevention, NEPA in the era of ADCs. So usually highly emetogenic drugs we used to give, definitely we are using the three drug combination or four drug combination, but antibody drug conjugates, which we are using mainly nowadays, they also have a more incidence of nausea and vomiting. So that is why the requirement of this NK receptor antagonist along with 5-HT3 antagonist. So that is what we are going to talk about today. So to introduction of ADC, risk factors for nausea and vomiting, unmet need for ADC, and clinical study of ADC induced nausea and vomiting, and guidelines to manage ADC induced nausea and vomiting. So this is what we are going to cover in this topic. So ADCs we commonly use are trastuzumab deruxtecan, adotrastuzumab, that is TDM1, polatuzumab vedotin, brentuximab, and inotuzumab ozogamicin, which is not available in India. So most of them are there in clinical practice, maybe 2 to 3 years. So risk factors for these nausea and vomiting caused by the ADCs are during chemotherapy various clinical factors including the drug type and post-related variables. Vomiting rather than nausea is used as an indicator for appropriate category, and previously reported risk factor for nausea including age, female sex, history of previous chemotherapy induced nausea, vomiting, motion sickness, morning sickness during pregnancy, little or no alcohol use, non-smoking, anxiety, and high treatment expectations of nausea and vomiting remain same for this EDC also, and no data to determine whether these risk factors for EDC induced nausea and vomiting. But these factors definitely may increase the nausea and vomiting when patient is receiving this ADC. So these are the different mechanism of action with examples. So microtubule drugs are there, and DNA damaging drugs including the topoisomerase inhibitor and DNA damaging drugs are there. So we commonly use this inheritor in breast cancer, and Cadzilla TDM1. It is a the drug conjugate is the microtubule disrupting drugs. So this is how these drugs and other chemotherapy, other ADCs are like polatuzumab vedotin are available. So I think most probably I will not go into details of this. So most of the polatuzumab vedotin, enfortumab vedotin we use in the breast cancer FGFR inhibitors. So and then these are not available. I think tislelizumab, tislelizumab vedotin, and other these drugs may not be available. Especially the belotazumab and enfortumab, they are also considered as a hematogenic drugs when we are treating the patients with these drugs. So emetic risk associated with antibody drug conjugates involving the evolving technology led to new indications and high level of effectiveness. So toxicities are mostly due to release of the payload at off-target sites and bystander effect. So whenever payloads are released after entering into the tumor cells, so that is when the nausea and vomiting, the chemotherapy is released. So then the patient will have the nausea and vomiting, toxicities will come up. And TDXD, sacituzumab govitecan are classified as a moderate or high level risk of nausea and vomiting. Adverse events should be prevented, closely monitored, and treated with adequate supportive care. Understanding the managing toxicities with ADC are critical to the continued development of new ADCs. So, GI toxicity is one of the most common non-hematological toxicities associated with the use of several approved ADCs like TDXT or sacituzumab govitecan. So, incidence of nausea, vomiting, and diarrhea was significantly higher with these novel ADCs than reported with TDM1. So supportive therapies initially, when the clinical trials were done with these drugs, were not mandatory and were left to investigator choice. But when they have started using, they have seen that the reduction in the nausea and vomiting level with these therapies. So. So these are the FDA approved drugs where the incidence of nausea and vomiting has been known. So enfortumab vedotin, which is used in the urothelial carcinoma, it is nausea is around 23%. Grade 3 or more than grade 3 is not there. Even the mivituximab, which is used in platinum resistant, not available in India, can cause nausea around 29%. Here also more than grade 3 toxicity is not there. Tisotumab vedotin, recurrent metastatic cervical cancer. Once again, it is not available. Nausea is around 27%. And most of the incidents by cycle, if we go by Destiny Breast for trial, the TDXD, we can see here in cycle 1, nausea and the vomiting percentage is 63% and 22% respectively, compared to the treatment of physician choice, where it is around 19.8 and 6.4 respectively. And once the use of this combination of anti-emetic were used, then cycle 2 and cycle 3, there is a reduction in the nausea and vomiting. So emetogenic potential of this TDXD and sacituzumab govitecan is increasingly recognized. And despite some prophylactic use, there is a high rates of nausea and vomiting, especially 73% in the Destiny Breast 04 trial. So the NCCN guideline, they have labeled TDXD and sacituzumab govitecan as a highly emetogenic, whereas ASCO and ESMO, they have labeled it as a moderately emetogenic drug. So long delayed nausea and vomiting is also a concern with ADCs. So we can see here median time to onset with nausea is around 3 days, and median duration of nausea is 10 days with TDXT, and it is 8 days and 5.5 days respectively with SG, and median duration of vomiting are 3 days and 1.5 days with SG. So clinical implication is can last for nearly half of the treatment duration, and quality of life is deteriorated with this. So we can see here the different percentage of nausea, vomiting, grade 3 and any grade is almost, we can see here in different Destiny Breast 01 trials to different breast Enhertu trials, where the Enhertu has been used in different trials of these things. So almost it is around 55 to 70, 70 to 80%, and even the vomiting is also around 30 to 40 for 50% results were there, and even grade 3 were around between 5 to 8% in different trials. So impact on treatment. The drug discontinuation rate was there, whereas in TPC it was not there. In vomiting also it was there, whereas drug reduction associated with nausea vomiting is around 4.6% compared to 2.3% in the treatment of physician choice. Even drug interruption was required around 1.3 compared to 2.3% of the patients with TPC. So use of prophylaxis was not mandatory but was recommended and administered in accordance with institutional guidelines. So we can see here almost 50% of the patients in the TDXD arm has received the anti-emetic prophylaxis compared to 37% of the patients in the treatment of physician choice, indicating that these ADCs are highly emetogenic drugs. So impact on quality of life, definitely, most of the patients, some of the patients we have seen, whenever nausea and vomiting is there, they hesitate to come for the second cycle of chemotherapy. So definitely the quality of life is impaired, and as per this guideline, this trial also, there is an impairment of quality of life. So the unmet clinical need is there in managing long delayed nausea and vomiting, and identifying effective long-acting antiemetic protocol is essential. Most of the whatever the available triple drug therapy or quadruple drug therapy, they are more helpful in acute and delayed nausea vomiting, and long delayed phase is little bit concern, which can be overcome by this nipitant and 5-HT3 antagonist combination. So NEPA patients who are receiving TDM1. These are the 62 patients were treated with the TDXT. 53 patients had a reliable information on antiemetic prophylaxis, and 15 patients with additional risk factor received NEPA plus DEXA, and 38 patients received 5-HT3 plus dexamethasone. And they have seen that during cycle 1, 58% of patients in 5-HT3 group had nausea, compared to 60% in the NEPA group. More grade 2 and 3 events occurred in 5-HT3 group. Vomiting was 21% in the 5-HT3 group and none in the NEPA group. So indicating that NEPA controls better nausea and vomiting compared to the 5-HT3 antagonist alone. So similarly, when this NEPA was continued in the cycle 2, so any grade nausea has decreased from 100% in the cycle 1 to 53% in the cycle 2, and any grade vomiting decreased from 47% in the cycle 1 to 13% in the cycle 2. So indicating that effectiveness of this NEPA whenever we are using in the ADAC induced nausea and vomiting. So even real world experience also shown that this TDXD, I mean this NEPA is going to be reducing the incidence of nausea and vomiting. So double versus triplet antiemetic prophylaxis, an exploratory study was done in Japan, where 5-HT3 antagonist with dexamethasone, 5-HT3 antagonist, NK1 receptor antagonist, and dexamethasone was done, showing that overall control of nausea and vomiting is robust with this NEPA combination compared to the 5-HT3 and dexamethasone combination. So DEXA sparing NEPA was also done. Study was done. So indicating that dexamethasone sparing, we can use this NEPA, oral NEPA for prevention of chemotherapy-induced vomiting in high dose cisplatin. And so they have also shown there is a without dexamethasone, this NEPA can be substituted without whenever we have a contraindication for using dexamethasone, especially in highly diabetic patients, uncontrolled diabetes patients. So non-inferiority of DEXA sparing regimen compared with the reference treatment was demonstrated for primary endpoint of overall phase complete response in the per cohort patients, as the lower boundaries of the confidence interval was met. So similar results for both DEXA sparing regimen was also observed during the delayed phase. So guidelines as per the non-AC chemotherapy regimens are there. So 4 drug combination is recommended. High AC definitely 4 drug combination: 5-HT3 antagonist, dexamethasone, NK receptor antagonist, and olanzapine. Whereas moderate hematogenic like carboplatin or oxaliplatin, 3 drug combination with NK receptor antagonist is included. Whereas in moderate and low, 5-HT3 dexamethasone, and low it is either 5-HT3 or dexamethasone, which we use in our clinical. So these are the different guidelines for vomiting and management in case of ADC. So most of them they recommend ADCs during the TDXT. So different cycles, if it is there, dose reduction as well as dose interruption, if there is a continued nausea and vomiting, that is what they have mentioned in this. So I think with this I will conclude. So any questions we can take up, I think.
Thank you, Dr. Srinivas. Excellent talk on the journey of that NEPA in management of our day-to-day the cancer management, that especially dealing with the nausea vomiting. Just one question, Dr. Srinivas, sir, like what is your practice? Because when we had a trial like even TDXT that in breast cancer, even lung cancer also, we didn't the guidelines was not come. We never used to give because like TDXT is like similar to other monoclonal antibody. If you give a Dexona, and anyway, that monoclonal antibody never is to give the antiemetic, even simple antiemetic also never is to give it. Yes, we to see a lot of nausea vomiting patients, and later we try to add like a primary prophylaxis was not recommended when they started nausea vomiting. Then they started to allow to use this antiemetic, and later definitely the guidelines has come because we are practically seen when in the clinical trial and even the day-to-day practice. Now the guidelines is there. Now, like especially when you're dealing with the ADCs. Do you think that the Dexa sparing that you'll use it or just you, how do you manage?
Yeah, I mean,
Now TDX,
we are not
you
using
want
that
to give a
Texas.
triplet
Yeah, we are using
triplet you'll
triplet
use.
only. I mean, only in AC and combination using quadruple combination. Olanzapine we add when there is a persistent nausea and vomiting even in second cycle, but most of nausea and vomiting is controlled with this triple combination itself. And usually Dexa sparing combination I have not used. Only if there is a uncontrolled diabetes is there, we are not able to use this steroids, then only use. Otherwise, we have used most of the patients with steroid only actually.
Yeah, because little bit I was little bit hesitant because chemo, okay, you can use a triplet, or when you're using immune checkpoint inhibitor or monoclonal antibody or ADC, that because you don't have the ADCs for the DEXA sparing, you have a data for the cisplatin. But I feel like if you want to try that like a NIPA with that this DEXA sparing can be tried than the chemotherapy. That's the more thing because to have a best anti-cancer control, we'll be worried actually if you use the dexamethasone, the efficacy of immune checkpoint inhibitor and even ADCs or even a monoclonal antibody, it will come down. That's what many times we never used to start. Now guidelines is there that I feel that the DEXA sparing should be tried in these aspects and we to see the regimen also we to see that cisplatin and highly hematogenic drug, yeah, triplet. Sometimes we use a quadruple that then olanzapine also will be trying to do use it actually. Thank you, Dr. Srinivas,
Thank
for
you. Thank you.
excellent and the talk for this from today's event. Thanks everyone, all the speaker, Dr. Aditya, Dr. Spurti, Dr. Amina, Dr. Ravi Tippeswamy, Dr. Vinu, Dr. Srinivas, and Dr. Mansi for taking their own time and to talk on the respected talk and for to make this scientific event successful. And a special thanks to Glenmark team, Glenmark sponsors, and Dr. Reddy's for supporting this today's meeting and also like I I thank the organizing team also to supporting this technical and technical support of this today meeting. Like thanks to Tarun and team. It's a very interesting the discussion today what we had. Thanks all the participant and those who are supported for this today's meeting. Good night, everyone. Thank you.
Thank you. Thank you, sir. Thank you, everyone, for joining. Thanks to my colleague Anjali and Jhalak for their efforts. Thank you. Thank you, sir. Good night, everyone.
Thank you, ma'am.
Thank you, support team. Thank you, sir.